Hello, good evening, viewers, and welcome to your favorite medical show, Ask Dr. SAWH. We're coming to you live from TBN Studios right here in Georgetown. And I just want to say thank you to every one of you that came out back and supported us on the show and bringing you this information about health. And the numbers are amazing. And myself and Dr. SAWH, it's with much gratitude that we say thank you so much for sharing this information, because as you know, I remember growing up from a very small, as a small boy, you always hear health is wealth. So let us all be rich in health. Good evening, Dr. SAWH, and welcome. Thank you for joining us from England again.
Thank you, Akash, and good evening to you and the viewers.
Wonderful. So, Dr. SAWH, we were back last week on this platform, and the numbers are amazing. We have quite a number of questions to ask in the second segment. So I'll be getting to those questions very soon in the next segment. But for tonight, we are talking about heartburn, acid reflux, and reflux symptoms. So I want to get straight into it, because I know a lot of people have suffered with this. From, I think, maybe once or twice I've had some instances where I've tasted this bad taste in my mouth, and thankfully I don't have that. So I can imagine people who are going through this. So in starting, Doc, I want to ask you, what is acid reflux and what causes it?
Okay, lovely. Yeah, no, good question. I mean, you're right. Every one of us at some point would have acid reflux time and again. It is estimated that about 25 to, some data has shown, 25 to 40% of the U.S. population have had reflux at least once a month. And 7 to 10% of the population would have had reflux on a daily basis.
Wow.
So if you talk about 300 plus million people, close to 10% would have reflux on a daily basis. 30 million plus people
would
have reflux. So it's a very common condition, and we see that. I see that a lot in patients coming in with, and of course it manifests a lot of time with chest pains, and of course that's always a red flag for patients. But what is acid reflux? And by definition, it would be reflux of gastric juices into the esophagus, or a backflow of gastric juices into the esophagus. So if we just put a picture of, ask Robert to put a picture of the gastric tract,
yes,
and I'll show where the esophagus is, so from the mouth, where you come down into the gullet or the esophagus. And then you have the stomach. You guys can see that.
Yes, that's right. Yes, it's there, Doc. Yes, you can see it.
Yeah, so the stomach, and you see in between the stomach, the esophagus pierces through the diaphragm.
Yes.
And that's where the stomach is below that. So above the diaphragm is that separation between the chest and the abdomen. That's called the diaphragm. The esophagus comes down all the way to the diaphragm, then it enters the diaphragm and into the stomach. Now, so usually at the bottom of that esophagus, you have a sphincter. It's like a muscle, and it's got a tone. So it's a right. So we call that sphincter. And the sphincter closes to prevent acid. Remember, the stomach is quite acidic. And that's where all the digestion and all the juices, all the juices get in there. Now, if that sphincter is weakened in some way, you would have a backflow or regurgitation of acid into the esophagus. So that is actually the mechanism, and that's why we get, most of the cases, that is why we get acid reflux. It is because of backflow or regurgitation of the gastric juices, which is acidic, into the esophagus. And usually it's caused by weakening or weakness of the sphincter.
That's right.
There is not maintained. And it is not as simple as that. It's a little bit more complex. Not only the sphincter can be weakened for mechanical causes, that is physical, chemical, physiological causes. There are certain nervous systems that keep this system tight. If those nerves are affected, you can have that. There is also a mechanism where the esophagus motility, the movement of the esophagus pushes down juices and enzymes down, or so it dilutes the acid. So if you have an impairment of those saliva, so the esophagus itself, the saliva from the mouth goes down the esophagus and it neutralizes the acid that comes up. So if you have a mechanism where that saliva system is impaired, the motility of the esophagus is impaired, or you have the sphincter is weakened, all of that would cause reflux, acid coming up into the stomach, and that is your definition, or that's your principle or your underlying cause of reflux. Now we can look at, that's a mechanism, as in, but let us bring that out in reality. Why does the sphincter get weakened?
Right.
If your pressure in the abdomen is high, it squeezes the stomach, so you get high pressure in the stomach. It pushes it weakens the sphincter and pushes up the acid. Mm-hmm. So think of any condition that causes increased intra-abdominal pressure. Pregnancy. Also, the hormones in pregnancy can also cause relaxation of the muscle. So pregnancy is one. Big meals. If you eat a big meal, it puts more pressure. You can have a bit more reflux. If food stays in the stomach for long periods, you can have more reflux symptoms. If you have, there are certain drugs, for instance, there are drugs that act on the nerve to the stomach, and they can cause reflux symptoms. So there's loads of conditions. If you have tight corset on, that squeezes your tummy, it pushes up, it causes more pressure in the stomach, it can cause acid reflux. So there are various mechanisms and lots of causes, but I'll come down to, when do we worry and when do we say, right, this is by far the most common cause, and we'll talk about that. Yeah,
Thank you.
ahead.
I want to ask you this, because you're talking about this, about a lot of food and what causes this, but some people say is that they have this acid issues when they eat certain types of food, like curry and spicy food. I want to ask you, is heartburn and acid reflux the same thing?
Not the same thing, because acid reflux is backflow of acid into the stomach, and it is manifested by heartburn. So reflux is a cause of heartburn, one of the causes.
Okay.
Because you can have heartburn for many other causes. And so what does heartburn mean?
Right.
What does heartburn means in English? Heartburn means there is a feeling of burning sensation in the chest. That's what we call heartburn. Where the heart is, behind the sternum, you have a feeling, a burning sensation. And it can be associated with bitter taste in your mouth, feeling in the throat. So we say, I am having indigestion, I'm having heartburn. You can have pains around the upper tummy. So all of that type of symptoms we will consider, we say, that is indigestion or that is heartburn. And when we look at the causes, reflux is one of the causes. So as a matter of fact, acid reflux is the most common cause for heartburn. So you understand the difference. Reflux is a cause of heartburn. Heartburn is a symptom.
Right.
So it is used, interchangeably, but it's not quite the same thing. One is a symptom and one is the cause of the other. Now, there are other causes of heartburn, for instance. If you have peptic ulcer, so reflux is different from an ulcer. An ulcer is an erosion into the walls of that stomach or duodenum or the esophagus. And then you have reflux is where the sphincter is weak and the acid comes up. You can have other causes for heartburn, gallstones, pancreas problem. There's so many other causes, but by far the most common cause would be gastroesophageal reflux disease. So in America they call it GERD.
Right.
In the UK, because they spell esophagus with an E.
That's right.
Whereas in the UK we call it GORD. That is esophagus with an O, O-E. So it is really similar. However, it is just one of the symptoms. Now, what are the other symptoms?
Right. Yeah, exactly. So tell us about the other symptoms. I mean, those are classic symptoms, but are there other symptoms that we might want to, we may not want to relate that think it's related to that, and we might just pass it off. You just drink. Some people say, man, you just drink a little cold milk or something, you're good to go.
Well, yeah, there's some logic in that.
Yeah.
But what are the other? So heartburn is one of the symptoms of acid reflux, and of course you have other symptoms. You may have a feeling as if the food is coming up, so we call it regurgitation. So how many times you've eaten and you say, right, I can feel the curry.
Right.
So you can taste it. You have a feeling of acidity in the mouth, so you have that bitter taste in the mouth. You feel as if you're bringing up the food you just actually eating. So we get regurgitation, we get heartburn. You can have a feeling of there's a lump in the throat. So sometimes with acidity, you have a feeling as if something is stuck in your throat. And lots of times patients come with that. Global symptoms, we call it, a sensation of a lump in the throat. You can have chest pain or abdominal pain. So the tummy, we call it, the top of the tummy is called the epigastric area. You can have pains related to acid reflux. Now, so those are your typical symptoms. And then you have what we call atypical symptoms, where you can have change in your voice. You have hoarseness. We have talked before, when I talk about chronic cough, I said acid reflux is one of the causes of a chronic cough. So patients with acid reflux, they can cough for long periods of time. Importantly, lots of people, if you have chronic reflux problem, you can have erosion of your teeth.
Oh,
so it damages the enamel of your teeth.
Is the acidity so strong, right?
The acidity is so strong, yeah. And with constant reflux, of course, it can also cause in your throat, the vocal cords, that's your voice box.
Yes.
The vocal cord, you can have inflammation, you can have polyps formation. So reflux is not just heartburn, that is one of the symptoms, but you can have quite a lot of other symptoms associated with it.
Great, Doc. But how does one then investigate if you have early stages of this of acid reflux? And how can you do this at home, or do you have to go to a doctor? How do you investigate this, Doc?
Well, investigation involves quite a bit in terms of, the most common form of investigation would be, or to establish if patients have chronic reflux, would be to put a camera in their stomach, and you will see, lots of time you would see the cause. But they say evidence, the data is telling us about, you can find the cause in about 70% of patients by putting a camera. And 30% of patients, you can't find the cause. There's nothing.
Wow.
It looks normal, but you can still have reflux, but it is not so profound to cause damage. Because when you put in the camera, what you're looking for? You're looking for inflammation in the lining. So you're starting from the esophagus. If it is inflamed, so it's red, it's inflamed, you can see that with the camera. As you go deeper down, so that's called esophagitis. As you go down into the stomach now, you'll see the gastritis, where the stomach itself is red and inflamed. As you go down, you can see ulcers, so you can have ulceration, we call a peptic ulcer disease. Also, there are times when long-standing reflux can cause cancer, where the ulcers become cancerous, or it damages the lining of the esophagus. It causes cancerous changes. We call the Barrett's esophagus, and later you'd have to monitor that they can transform into cancer. So, investigation. We'll come back to the complications.
Right.
The investigations will be a camera. You can also do a test called a barium study, where we give you something to drink and we do an X-ray, something like an X-ray, and it lights up as the barium goes down.
Okay.
So if you have a reflux, you will see regurgitation of the barium. So that's called a barium swallow. And if all of that comes back normal, and you want to prove indeed that there is acidity, high acidity refluxing, we do what is called manometric studies, or pH monitoring. So they put some probes into your esophagus, and it measures the acidity, and that is called pH studies or manometry. So there are various investigations, but come back to, it doesn't end there, because those are for your classic reflux symptoms that we think, this is as a result of acid coming up in the stomach. But if a patient has got heartburn, as opposed to, we haven't made the diagnosis as yet. We are saying, okay, this is heartburn symptoms, and I'm trying to establish, as I say, reflux is one of the causes of heartburn. You can have other causes. Then you may have gallstones. There are lots of patients with gallbladder disease. They can have reflux symptoms. So for you to diagnose that, you want to do an ultrasound. So an ultrasound is another test you can do. And a very common one that sometimes we forget, but it's common, and I do this routinely to patients, especially in my community, immigrant population, because the prevalence is higher. There's a bug that lives in the stomach. I would imagine in Guyana the prevalence is high as well. There's a bug that lives in the stomach called Helicobacter pylori.
Right.
And it can live in harmony.
I was going to ask you about H. pylori, Doc. I was going to ask you about that, yes.
So you can have H. pylori, and it stays in the stomach for in harmony with you sometimes, and you don't have symptoms. And for some odd reason, it can flare up, and it causes a disequilibrium of your acidity, cause you to produce more acid, and of course that can give rise to heartburn. Now, to establish that, you can do a couple of tests. And I've seen this, and I just want patients to understand, or the viewers to understand this clearly, because lots of time you go to a doctor and they do a blood test for you, and they say you've got H. pylori. Now, and they start treating you for that, but the blood test doesn't tell you if you've had H. pylori 6 months ago, or if you've got it now.
Right.
It is not, the blood test is a serological test, whereas an immunologic test, where if you have the infection, your blood produces immunoglobulin against the infection, so that stays in the body for a while. So you may have had the infection and it's gone, and the blood test is still positive. So the blood test is not an accurate way of establishing if you've got the infection. A more accurate way, if you have present infection, would be either we do a stool test, so the poo. We do, it's called a H. pylori antigen test, so you take a sample to the lab and they test that. Or you do a breath test. You blow and they measure, they do a breath test to establish if you have the infection. So these are important causes that so the investigation really is to establish the cause.
Absolutely. Doc, what's the name of this? What's the full name for H. pylori again?
Helicobacter pylori.
Helicobacter
pylori.
Helicobacter pylori. I have to remember that. I've been keep saying H. pylori all the time. But let's, I always want to ask this question though. With everything that we discussed, can this be dangerous? Can it be fatal?
Yes, of course. So when we look at complications, so we can talk about, so heartburn can be serious, and there are some red flag things we're going to look at. But when we look at complications of acid reflux by itself, think about acid coming up into your esophagus. So what happened over time? It damages the cells of the esophagus. So that's the lining. And over time, our body, the cells damage, and they start to change shape and form, and they become cancerous. So acid reflux can give rise to esophageal cancer. It can cause, so before you get a cancer, you get something called Barrett's esophagus. So these are changes that are showing that there's some your esophagus has got cancerous changes, and that is defined as Barrett's esophagus. What we tend to do is to, do surveillance, and we monitor that over, regularly. Of course, and you can do their treatment for that as well. It can cause stricture. So remember, it burns the esophagus. So it can cause stricture. Now, if you have a stricture in your esophagus, it causes food not to go down properly. So you have problems swallowing. We call it dysphagia. You can't swallow the food properly. A long-standing reflux, also reflux is associated with lung problem. Asthma reflux is associated with, and it is also associated with something called pulmonary fibrosis. There's a high incidence of pulmonary fibrosis in reflux patients. So the lung itself is supposed to be elastic and expands and contracts and expands normally, and when it's fibrotic, it gets stiffened or hardened.
Right.
So it can be serious. And of course, at the back of our mind, everyone who presents with long-standing reflux symptoms, we want to make sure they don't have anything sinister, something cancerous. Because, I mean, I'll tell you a story.
Mm-hmm.
When I joined, this is many, many years back, when I just finished training, and I joined my surgery, I remember this patient vividly because he was a patient that came in with a history of acid reflux. And, you know, he's been having his anti-acid tablets, and he didn't make anything out of it. But when I look at his record, he's had this for a long time. Now, you know, when you just finished training, you're excited about doing all the tests.
Right.
So I said, okay, let's start running some tests now on you and ensure that we're not looking at something more dangerous. And I did an ultrasound of this guy. He's been treated for years with acid problem. I did an ultrasound for him to say, okay, I have in patients with chronic symptoms that are not getting better, I would then go and do the next test and the next
right,
test and the
right.
next test. And the ultrasound came back showing that he's got pancreatic cancer.
Wow.
Sadly, this guy died now because pancreatic cancer is you know, it's usually when you pick it up, it's far gone.
Mm-hmm.
And so I would tell people it's not something that you should trivialize. I'm not saying that you should go and investigate everyone with acid reflux or indigestion problem,
mm-hmm.
but you should be selective. And I tend to investigate, I would say to patients, if you're under 40 years of age and you have reflux symptoms as a one-off, and I do some lifestyle intervention and manage you, and your reflux is gone, I don't need to do anything further.
Absolutely.
Because the likelihood, the data, the statistics is telling us that the likelihood of you having something serious under the age of 40 with a one-off reflux symptom is actually negligible. And if we manage you with just anti-reflux medication and some lifestyle changes, that's all that is needed, and that's a one-off. However, so we will have a high index of suspicion of more serious causes. If you're over 40 years of age and you're having reflux with other red flag symptoms, or you're having persistent reflux despite management. And what are the red flag symptoms? So the red flag symptoms would be weight loss. So if you have acid reflux symptoms that is going on for a period of time, mm-hmm. and you have weight loss, that should always be investigated. I always like to have a number in mind, meaning for patients to remember. So let's look at 5 things
right.
that you will have that will cause you to see the doctor and the doctor should investigate you. So we're looking at these 5 things. So weight loss is one. If you have difficulty swallowing, we call that dysphagia, you should be investigated. So I'm talking about further testing, that is camera, scans, whatever. If you're bringing up blood, so you're vomiting blood, mm-hmm. sometimes you can spit up blood, whatever it is, but the blood is coming from the stomach. If we do a blood test and you're anemic, so if patients are anemic and they're having long-standing acid reflux, they should have a camera, because we're looking also for cancer. Because with cancer, you bleed slowly, and you don't know it, and that can be a telltale sign. And if you have an epigastric mass, so in the tummy, so where your stomach is, if you can feel a mass there, mm-hmm. I would say that patient, you need a further investigation. So those are the 5 things: weight loss, difficulty swallowing, bringing up blood, anemic, and a mass in the stomach. By all means, those category of patients should be investigated. And of course, there are other patients, like somebody who's had, I tend to investigate patients who have had previous stomach surgery. For whatever reason, if they've had peptic ulcer disease in the past, you can have a higher risk of cancer from chronic ulceration. We'd want to investigate that. Patients on long-standing anti-inflammatory. So we talk about this drug, ibuprofen family of drugs.
Right, right.
About kidney disease.
Yes, indeed, last week.
Ibuprofen can damage the kidney. Also, ibuprofen can damage the stomach, cause acidity. Can cause ulceration in the stomach. Yeah. So if you've got a patient on long-standing painkiller, so all your arthritic patient who's saying they're taking ibuprofen all the time, and they have an acidity problem, they should be investigated for ulcer. And of course, chronic ulceration can also lead to cancer, so you want to look at that. And patients with a family history of cancer, you want to investigate them also.
Yeah. Doc, quickly, those 5 things that you mentioned there, everyone should be looking out for. I know that acid reflux affects people's lifestyle, Are there any major complications, though, that comes with it that acid reflux affect you in other ways that can incapacitate you in ways too?
Well, of course, it depends on the cause. So if I say to you that, okay, you're losing weight and you have acid reflux, by itself, the complications we talked about would be the risk of having cancer long term.
Right.
The risk of having strictures, the risk of having chronic ulceration, fibrosis of the lung, chronic cough. Of course, all these things would affect your daily living.
Right.
So it can, but depending on the cause now, if you have got pancreatitis or pancreatic cancer that is causing reflux and acidity, that can be fatal.
Yes,
that
of course.
will kill you. If you've got gallbladder disease, even cancer of the gallbladder system, the biliary system, you can have acid bile coming up. So you have an acid reflux manifesting as reflux, and that can be fatal. So yes, I would say reflux, trivial reflux, we all get reflux. We go out, have a binge.
Yeah.
One day, you come back, you have a bit of indigestion. That's your reflux that you will manage with your antacids and whatever. But no, chronic reflux is a little bit more serious, and it should be taken that way.
All right, because we got 3 minutes, Doc. We got 3 minutes more to go before we close up this here. I want to ask you about treatment, please.
Okay, fantastic. So in 3 minutes, we try to run this.
Yes, indeed.
So the important thing I always start with, lifestyle management. So there is something called anti-reflux lifestyle. Anti-reflux lifestyle. You maintain a healthy weight, you stop smoking, you exercise, you eat healthy, and you restrict your coffee to no more than 2 cups a day, and soda. So that, you could say that's the anti-reflux lifestyle. So you want to adhere to that. Smoking is very important. As a matter of fact, smoking also affect the sphincter. I talk about that sphincter because of the reflux. So we always would ask patients to quit smoking. And of course, yes, if you're having the symptoms now, how do we manage it with lifestyle? We want to do not eat within 3 hours of going to bed. That's an important thing. Instead of eating big meals, eat smaller meals. So you don't want, use a big meal at one go. The type of food, there are certain spicy food, acidic food, tomatoes, oranges. They have lots of acidity. Chocolate, talk about coffee, soda, and of course, you can lie down and have the head of the bed a bit elevated.
Right.
So that's your non-pharmacologic intervention. And then we all know the management. First thing you go to, you take some antacid. So antacids.
Right.
Pepto-Bismol, Gaviscon, whatever the antacid. So antacid is made up of 2 things generally, or some of them have got one each or combined. They have antacids and alginates. So antacid dilute the acid, and alginates form a layer on top of your stomach, so it goes above the food, and it creates a barrier for the reflux. So they come into like all these Pepto-Bismol and stuff. They've got a combination of those 2 drugs in it. So the dual action, they dilute the acidity and they form a barrier to reflux. Now, if you use that, and those are usually home remedies. So you'll start with that. If there's need now for your symptoms are not getting better, and we establish that yes, it is reflux and nothing more, then I would want to give you reflux medication. So reflux medication would be the common type. In the old days, we have H2 blockers, we call it. Zantac, I don't know if you heard of Zantac.
Yeah, Zantac, of course, yes.
Yeah, they were the older drugs, but now we have newer drugs. But a class of that drug we'd have is famotidine. They are H2 blockers, so traditionally they can still be used. And we have now a type of drug called proton pump inhibitors, and they're common as well. Omeprazole, lansoprazole, esomeprazole. They're branded like Nexium and Losec, and those are the brands. But they decrease the production of acid in the stomach. And what else? There are drugs we can also give to cause increased emptying of the stomach faster. So it causes peristalsis in the stomach, where the stomach empties, so you don't have a buildup of pressure.
Right.
And then last resort is you can have a surgery. In reflux disease, you can have an operation. It's called fundoplication. So where they go on the wrap part of the top of the stomach, they wrap it around the esophagus, so it strengthens and changes the whole anatomy of it.
Wow. Well, Doc.
So those are your.
Yes, that is amazing. I love even the viewers would say they love the way you would roll out these medical terms so easily. And on behalf of every one of us here, the viewers and all of us here, we want to say thank you for this information that you bring into us, Doc. We'll be closing now. Anything you want to say in closing, Doc?
Thanks again, Akash. I know time is always. I mean, I don't know. Sometimes I end up talking too fast.
No, that's all right.
To get everything out there. But I think with time constraint, we want to stick to half an hour in this first segment. So thank you again to you and your team and to the viewers.
Right. So thank you, viewers. As you know, we always say in the show, stay healthy. Join us in just a few for the next segment. We will be answering your questions from last week. Stay healthy, everyone. Hello, viewers. Welcome back. And this is your question and answer segment. This is the segment where you get to send in your questions and we answer them. Tonight, Dr. SAWH will be dealing quite a number of questions from last week. And Doc, I'm happy that we have so many questions this evening, and most of them have to do with last week's topic that we dealt with, which was chronic kidney disease. The first question we have here is, Doc, it says, so Doc, is it safe to say diabetes is part of kidney disease?
Well, they're related. So I would say diabetics, as I said earlier in chronic kidney disease, the commonest cause would be diabetes and hypertension. Combined, they account for 3/4 of all chronic kidney diseases. So I would say diabetes causes chronic kidney disease, and not vice versa.
Okay.
So it is. I mean, they're so interrelated that the whole mechanism in terms of diabetes, how it affects the body, it damages your blood vessel, it damages your nerve, and all those things impact on the kidney. So diabetes related to kidney disease, but and it's a cause of kidney disease. But kidney disease is not the cause of diabetes, put it that way.
Right.
So you could have kidney disease independently of diabetes. So kidney disease is not a cause, but diabetes is diabetes cause kidney disease.
Right. So the kidney could become collateral damage for our bad lifestyle too.
Well, definitely. I mean, as a matter of fact, it's all lots of the things in health. It's about lifestyle, and I try to emphasize. Sometimes I look at, I tell patients, we spend a lot of time going to do lots of minute, like genetic profiling, and we look at, I'm eating this, I need to get this organic food, and this organic, that. They're all good, yes. But if you don't do the basics, and you just believe I'm going to eat organic food and live long and healthier, but I'm not exercising and I'm still smoking and doing rubbish, you're not really doing any justice to your life. And so you have to really, and if I'm going to start doing genetic profiling and looking for which gene going to make me have a risk of having this disease in many years to come, but I'm living a bad, unhealthy lifestyle, smoking and drinking. So I think lifestyle, I cannot really overemphasize the impact of lifestyle on our health generally. Just let's stick to basics. Eat healthy, sleep well, drink enough water, and exercise. I mean, that's the foundation of good health.
And just to follow up with what you just said there, Doc, I always say that a lot of people don't realize how sick they are until they're really sick, because meaning that you're going about this, you're going about it, and you're feeding the progression of your sickness by whatever or if you have diabetes, you're feeding the progression of this thing by not living healthy, but at the same time you're damaging so many other parts of your body, and that is why, Doc, these programs are so important. So let me go to the next question, Doc. Thank you so much for that. As we were talking about last week, we were talking about as you mentioned, certain types of drugs can damage the kidneys, and you just mentioned also damage the stomach. Somebody asked here, what about strong painkillers? Can this damage your kidneys too?
Absolutely. There is something called analgesic nephropathy. So nephropathy is a pathology of the kidney, right? It's when your kidney is diseased. We call it. Nephron is the unit that filters the blood, right? And produces the urine. We call it the nephron. So nephropathy is a pathology of the nephron. Now, so there's a term, I'm just trying to explain that there's a term that is well described in the textbook. It's called analgesic nephropathy. So what happens, the painkiller itself damages the nephron. It damages the building block, or that unit, the mechanism how the kidney works, where the blood filters into that filtration system. Analgesic nephropathy is what it damages those parts of the kidney. So it is a well established cause of kidney disease, and I always, we talked about, even just a few minutes ago, I talk about ibuprofen affecting the stomach and ibuprofen affecting the kidney. Strong painkillers, they can cause ibuprofen also. They can decrease blood flow. It works with an enzyme, prostaglandin, and it inhibits that, and you have a decrease in blood flow to the kidney. So if you have a decrease in blood flow to the kidney, also you have interstitial nephritis, where it damages the nephron itself. Of course, you can have analgesic nephropathy.
Wow.
So it's a well-established case, and I would advise patients, you have to talk to a doctor. They will give you the most appropriate analgesic, as in pain relief, and for the shortest possible time. And if you need long-term pain relief, of course, we will do the monitoring system. We'll ensure that, once we are given is safe and your kidney function is good, and if it has an effect on that, we'll monitor that.
Great. The next question here, Doc, is, Doc, can damaged kidneys cause blindness?
Damaged kidney causing blindness is usually, they're related, but I wouldn't say. So yes, to an extent, the answer to that question is actually the answer. I'm just thinking, to give you a medical, genuine answer that I have evidence for. So there is a condition where when you have damaged kidney or you get kidney failure, you become uremic. Uremic is that your urea level is high.
Okay.
And that's the uremia symptoms where you are toxic. Your body's got all these urea toxins in you. And that urea itself, that uremic state, can damage the nerve in the eye, the optic nerve, and it can cause blindness.
Oh.
So that's a direct relation. I was just trying to think of a direct relation, because the question is so structured where the kidney damage the eye. But here what? There are so many chronic kidney disease, they're linked to the eye by so many ways, because the same mechanism, how you have damage to the kidney, the causes it damage the eye as well. So patients with diabetic kidney disease, they have diabetic eye disease. So we call it diabetic retinopathy. So it damages the blood vessel in the eye. How your blood vessel in the kidney is damaged by diabetes or high blood pressure. Likewise, the blood vessel can be damaged in the eye as a result of the blood vessel can be damaged in the eye as a result of diabetes or high blood pressure. So you get retinopathy. That's well established. Kidney patients also, chronic kidney failure patients also, they have higher risk of cataract, and for also glaucoma, they have a higher risk of those conditions. So there are so many pathology that is, I mean, a mechanism of action that is related to the kidney and related to the eye, that they are linked together.
Wonderful. Okay. The next question I have here, Doc, is, Doctor, what is the danger of calcium buildup?
Yeah, good one. So we know that when we say something is calcified, and as a matter of fact, when somebody's got chest pain and we go in and look for one of the tests you can do to check if your blood vessel is getting smaller, that is, if you check for buildup of calcium plaques. So cholesterol calcium plaque can build up in the arteries and it causes blockage. So calcification of your arteries happen over time as you get older, and also as a result of injury, inflammation, you get calcification. So calcification blocks the blood flow. So long-term high level of inflammation can give rise to calcification, or high level of calcium deposits. So chronic kidney disease can have high calcium buildup because the bone, I told you the mechanism of the vitamin D and the bone, you're not having enough conversion of vitamin D to regulate the calcium level. You can have more calcium in your body, and you can have thickening of the blood vessel. If your blood vessel is thickened and hardened, what do you get? You have increased risk of stroke and heart attack and all the other things that come with it.
Okay. The next question here, Doc, is glaucoma caused by kidney disease? Or they said, Doc, is glaucoma caused kidney disease? But
I said to you earlier that
right.
Cataracts, glaucoma,
yes,
retinopathy, there are higher risk or incidence in kidney patients or kidney failure patients. So there is a direct correlation there where these patients have a higher risk, but they're not the cause of it.
Right.
Such.
The next, I find this next question very interesting. It says here, Doctor, is it safe to use conventional and herbal medicine at the same time?
Well, in relation to us talking about kidney disease, I would just advise caution in the use of herbal medicine. Once your kidney is bad, don't even go close to anything herbal. The reason is we don't have medical evidence right now that is published, data and recommendation or guidelines that I know of that would tell us that herbal medicine is a good alternative for kidney disease, because we know the kidney got to process drugs. So you got to study whatever it is. We have to study it on the effects on the kidney. Now, there are two components to that question.
Mm-hmm.
The two components would be, is herbal medicine by itself in chronic kidney disease good? In my opinion, I would stay far from it, or I advise patients not to take herbal medicine when they have chronic kidney disease, because the kidney is already diseased and we don't know how the dosage, how it works in the body. We don't know all these things. They haven't studied it as good as conventional medicine, right?
Yes.
And then the second component to that, is it good to take conventional medicine with herbal medicine? Now, there's also another component where you can have drug-to-drug interaction. So I wouldn't know. So when you take one drug, it can decrease. So lots of the drugs, the liver and the kidney process the drugs, right? Now, in the liver, there are some enzymes. To metabolize and break down this drug, you have enzymes in the liver. So if I'm taking a herbal drug, and my liver is starting to break that down and I'm using up all these enzymes, then I have less for the conventional drug.
Right.
So the conventional drug can build up in our body. Mm-hmm. It's not being metabolized. It's not being, it's not breaking down as it should, at the rate as it should. So you can have a buildup and it can be toxic. So I would say, unless there's an expert on, you are consulting an expert in herbal medicine, I'm not a big fan. I would not dismiss it. The things I don't know, I don't pronounce on, and I don't know enough about herbal medicine to advocate for. And however, the things I advocate against would be evidence that I have to say it can do harm.
Right.
But I'm not a big fan of combining the two, nor would I say in patients with chronic kidney disease, please stay away from herbal medicine.
while I'm an advocate for natural health and wellness, also I've also known of cases where people would have used, at least one person who would have been using herbal medicine, and it ultimately led to his death, and unfortunately. But here's what I will say, that a lot of times, Doc, I believe that while these leaves or stems or barks or roots that we're using, mostly those are the things we use in herbal medicine, especially if you go to the herbalists and at the various markets. There may be one property in that thing that may be good for you, but there might be 1,000 toxins that we haven't extracted because we're using it in its entirety. And
absolutely. Well, that's the gist of it.
Yeah.
If you look at medicine generally, lots of medicine are made from plant product.
Right.
And what do, they study the active ingredient. We call it the active ingredient.
Right.
We extract that. We then put that in animals to see how they react, how the kidney will function, or the liver will function, how they will function. And then we say, fine, it looks good in animals. Then we take it to the next level and we test it in humans.
Right.
So we do what is called controlled trials.
Mm-hmm.
And then when we see, right, we've tested it for so long and we continue. That's how drug company, that's how you get development of drugs. And then when we say, fine, this is safe to use, then we give it to the population. And even while it is being used in the population for the first 5 years or 10 years or whatever, we have alerts. The doctors are, it's recommended that the doctors would alert the drug company to say, hey, these patients have prescribed this drug, a new drug to 10 patients, and 5 came in with some other symptoms.
Right.
And that is why you have the side effects being reported. So these things are well studied. But as I say, I don't want to be, when we advocate, as you rightly said, we advocate for natural things.
Right.
So let us not confuse natural things from herbal.
Yes.
Natural things, you want to eat healthy, you want to exercise, you want to sleep well, you want to drink enough water.
Mm.
I mean, those are natural things.
Right, right.
So nothing is stopping us from doing the natural things. And the evidence there tell us, okay, we eat lots of fruits and vegetables, it's good for us. Green leafy vegetables, whole grain, whole meal, and whole grain food, good for us. Let's eat that, and that is good enough. That's your natural we're talking about.
Right.
And then we'll think about the other natural, herbal medicine.
And before I go to the next question, just to say that what you're saying is that, look, we're not against this, but you know what? Just to be safe, consult a doctor. Just don't go take this herbal thing because you can be causing more damage already to a damaged kidney. Can't deal with it. There might be 1,000 toxins passing through there that just pull the last straw. You never know. So, all right.
Absolutely.
Yeah.
No, you're spot on.
Yeah. So the next question, Doc, here is, Doc, when there is numbness and tingling of the fingertips, what causes that?
That's a loaded question. So, sensation, I always say to patients, numbness. If you get a numbness, you're telling me something is wrong with your nerve. Simple. So you look at a symptom and you try to dissect it. I'm feeling numbness, burning, tingling, whatever it is. It is a sensory stimulus. And that is a sensation, is as a result of a nerve pathway is affected. Now, what can cause a nerve to be affected? So, it's difficult without understanding the whole context. If it is one finger, or one hand, the nerve can be trapped. So the common cause for the fingers and one side generally is a trapped nerve. Now the nerve can be trapped in the wrist, and if it's trapped here, it's called carpal tunnel.
Right.
You heard of carpal tunnel syndrome?
Yes.
But classically, patients there, trapped nerve in the wrist, they get pins and needle numbness, tingling. You can have various symptoms, but the little finger is spared. So one of the ways, if you have numbness and it doesn't affect the little finger, you could tell yourself, hey, that's carpal tunnel.
Right.
You can also, patients who do this, when you sit on the desk and you get your elbow on the desk.
Yes.
All right, so you elbow like that and you sit on the desk for long periods. You can cause irritation of the nerve in the elbow. So then all the nerve comes out there. So that can also cause numbness in the fingers. You can have, as you go up, you can have trapped nerve in the shoulder, you can have trapped nerve in the neck. So disc prolapse, arthritis of the neck, prolapse disc of the neck. Now coming to the brain now, because I'm trying to trace, you have numbness in the finger, that signal, for you to get a numbness, there's a signal going through the nerve, and it goes to the brain. So we look at the wiring system. So we talk about the nerve, what can happen to the nerve. In the brain, you can have problems in the brain. If you have a brain tumor, if you have a stroke, if you have something present, the brain sends where the sensation is, it is responsible for a part of the brain. So anything to affect that part of the brain can give you manifestation. So you see stroke patient get weakness in the arm. You get, you can get sensory abnormalities, sensation problem as a result of that. So the brain can be affected. But besides stroke and tumors and causes, you can have what we call degenerative changes in the brain. And you heard of multiple sclerosis.
Right.
The multiple sclerosis can also cause, so where the nerve, the sheathing of the nerve can be affected, and you have degeneration of the brain, and you have numbness and sensory problem. And of course, if you get numbness in both sides, we call that glove and stocking neuropathy. So one side we're thinking about one nerve, one section.
Yes.
If we have it on both sides, I'll be thinking, there's something generalized that is affecting my whole body, because it's symmetrical on both sides. And a classic one in diabetes, in diabetic patients, they have something called glove and stocking neuropathy. I would have talked about that when I spoke about diabetes. So glove,
right,
hands, stocking, both feet, you've got numbness and different sensation. You get pins and needles, you can get numbness, you can get burning sensation, and that can be as a result of uncontrolled diabetes or diabetic neuropathy. So long-standing diabetes affects the nerve, and that is why in diabetic patients they can injure themselves. Patients walk on something, they get a nail stick injury, and they don't even know. They don't feel in their leg, in their foot. So, and also some toxins, some toxic stuff like and low vitamin B. So vitamins, remember, we need nutrients for the nerve to function. So if you have nutrient deficiency, you can have pins and needles, and also some toxins like lead poisoning, mercury poisoning. They can also they can affect the nerve. So there are many, many causes of that. I'm just trying to do it in a systematic way.
Indeed.
For patients to understand. So it's about taking a history, doing an examination, and then we can, dissect and say, fine, this is your cause.
Great. We've got just under 10 minutes to go, and we've got 3 more questions to go, Doc. So let me get to the other one right away. So when do you go on dialysis? The only known cure, and is the only known cure for chronic kidney disease a kidney transplant?
All right, so dialysis, as I say, we start preparing you when your kidney function, EGFR. We talked about EGFR, and that is the filtration rate, where the blood flows in to this filtration system, and the rate of flow and how you form in the urine. When it goes under 15, I will start preparing a patient for dialysis, or send that patient to the specialist to get preparation for dialysis or transplant. So we start thinking, hey, your kidney is going down rapidly. As it goes under 10 now, you're coming closer. So there is no one factor that we look at to say, hey, you're ready for dialysis. So if you have a little bit of function remaining, we may choose to say you can have their different types of dialysis. They have what is blood dialysis. We call it hemodialysis. And then you have peritoneal dialysis, where they filter the fluid in your abdomen. Mm-hmm. So they put some liquid in the abdomen, and then you drain it back, and the abdomen works as a filtration mechanism. So that is peritoneal dialysis. And usually, if patients have some remaining kidney function, we allow peritoneal dialysis for a while. And of course, it has to do with access and lots of other factors when we decide on either peritoneal or hemodialysis. But hemodialysis is filtration of the blood. Directly, we create a fistula, the blood flows through one section, filters, and flow back into the body, right? Mm-hmm. Now, so I said to you, if the kidney shut down totally, right away, there are electrolyte abnormalities will happen. You will have a buildup of potassium, and if the potassium gets too high, you can get a cardiac arrest, the heart can stop. So that's an indication. So there are various things we look at. We look at high potassium, that's an indication and we can't control it.